Well, hello everybody. Let's see, who's Fim? I'm Paul. We're with the Pain Management Echo Clinic. I'm with Dr. Lewandowski and Dr. Patterson. And first, big thanks to Dr. Klass for allowing us to put this on consistently. Our newly minted Director of Echo, Mr. Chris Marchand. Congratulations, Chris. And Troy, who makes all of the IT work. Thank you very much, Troy. Nice. Yeah. All right, let's start. To my right is Dr. Lewandowski. Go ahead and introduce yourself.
Sure. I consider myself a pain management helper. I have a PhD in psychology, and my experience for the last 34 years is working with people who have kind of persistent chronic pain. So I'm a psychologist addressing some of the behavioral medicine, psychosocial issues in the pain population.
And I'm Dr. Dennis Patterson. I'm a physical medicine and rehab doctor who's subspecialized in interventional pain management. I'm board certified in both and have been doing pain management now for 10 years. And here just to give the best advice I can to you guys.
Wonderful. All right, now who do we have on? Who's joining us today?
So let's start with Dr. Van Gilder.
Dr. Van Gilder, where are you?
Lock.
What's that?
In Lovelock, Nevada.
Wonderful, welcome, good. I see Sumo over there. Sumo, who do we have from RSIC? He's still working on it. Who's Fim?
That's, I'm Dr. Marie McCormick from Renown.
Hello, Dr. McCormick, great to have you.
I'm getting ready to go back to primary care down at, I'll be at the pavilion at South Meadows, but also I'm going to try and get the rurals to start clicking in from Fernley and Fallon in the coming months.
Thank you so much. This is wonderful. Okay, and Jacques Ewing?
Sorry, Jackie Ewing Taylor. I'm with, actually with CASAT, and I'm one of the evaluators on the STR grant, so none of which you really needed to know. Good morning.
Good morning. Thank you very much. And ah, nice. Thank you. A little help from my friends. And where are you? Lori?
I'm not sure if we can hear her.
Okay.
And then the phone number is just someone calling in.
Sounds good. All right, so let's make this a real productive hour. Let's start off with some cases. Does anybody have any cases that you'd like to discuss? Any kind of staffing that needs to be done with any questions that you have regarding?
Really need to see you guys.
Go ahead, Paul.
Okay, with any patients that you have, whether it be substance use, psychology issues, pain management issues, we're here for you. And one of the ideas of the staffing is so that if you have something that's a complicated case, we can bring it out to the forefront. You can maintain your confidentiality. We don't need the person's name, but we do need to know some details about the case. And hopefully we can provide some optimal care for your patient by putting all of our minds together and kind of noodling out any issues that you might have that have already been explored and have already been tried or worked with. So are there any questions, concerns, issues with any ongoing patients that you have now? Okie dokie. So we're going to start off. Oh, my name's Paul. I'm a licensed alcohol and drug counselor. I have licenses in multiple states. I have experience in residential treatment, intensive outpatient treatment, individual settings, group settings. And the reason that that's important is because when you're in the different levels of treatment, you can recognize what each level of treatment is actually set up for. For example, residential treatment is 24 hours monitoring and structure, and that's the place that we call inpatient when the person has to leave for 28 days and they go into this little cocoon of being helped out spiritually, emotionally, mentally, physically. They're getting nourishment in all of those areas, getting healthy. And then what we do is we take them from that cocoon of healing and health, and we drop them right back into the environment that they were using in before with no coping skills and no real experience in that environment trying to survive. So that's where intensive outpatient comes in. Intensive outpatient would be a step down or step up into, depending on where the person is. And that's 3 hours of treatment, 3 sessions a week with individual counseling and support group while they're in their environment, so that they're able to work with a group to function in an abstinence-based kind of environment, trying to utilize and experiment with their coping skills. Then the next step is outpatient. So see how we're titrating down? So the idea here is it's to recognize where that person would have the optimal chance for success. So one of the things that we do in every level of treatment is we use screening tools. Screening and assessments are kind of like a moving puzzle. You have to figure out where the person is consistently. Now, a screening tool, an assessment tool, the tests, the questionnaires, all of that stuff is just to get a snapshot of where that person is at that moment. Also, we have to take in consideration the skill of the provider who's asking the questions, the environment that the person is in, the ability for them to recall, their amount of defensiveness in answering the questions. So as we build the relationships with our patients, we're able to see, okay, they're moving, either progressing or they're not progressing. Let's see. So today we're going to review the need and benefits of screening for substance use and/or mental health disorders when considering opioid treatment or any other kind of treatment. And keep in mind, I'm going to be going over a couple of screening tools that are really easy to use in your office, but then these screening tools can get real intricate real quickly, and my experts over here utilize quite a few screening tools, so we'll be able to tap into their expertise to tailor make the screening tool exactly for your population. For example, the population that I work with right now has a lot of trauma, and so ACEs would be an appropriate screening tool. Other places, if you're a specialist in opioid or pain, then you want to drill down more towards that pain area, but you still want to get a whole idea of where the person is. You also want to identify co-occurring medical issues which are caused or impacted by mental health or substance use. And then we're going to discuss strategies to implementing these screening and assessment tools efficiently while still honoring your time, and examine different options with screening and assessment tools. Well, here we are. We have an opioid epidemic. CDC data. We're looking at about 142 overdose deaths in the United States daily. That's more than car crashes or gunshots combined. So we have this epidemic that we're dealing with. We have not very many people getting treated or getting the appropriate level of treatment. And we have a lot of people, about 40%, with substance use disorders also have mental health problems, but less than half of those people are receiving treatment for either issue. So screening, hopefully, or assessments will give us an idea of where the person is. This is a complicated slide, it's kind of difficult. Yeah, let's go up to the mental health. That's the upper left-hand side. Look at that, mental health. Nearly 18% of adults in the United States reported having a mental, behavioral, or emotional disorder in 2015. So this is the latest information that we were able to get from SAMSHA. We have women saying they have about 21, a little bit over 21%, having mental, behavioral, or emotional disorder. This is all self-reported too. Look at our 18 to 25-year-olds. They're young people. 26 to 49, not far behind. And then there's my American Indians, Alaskan Natives. Okay, now this is all self-reporting. This is people who have emotional pain that are self-reporting they have emotional pain. Let's go over to this substance use. There's our stigma right there. Okay, so this is self-reporting, and many people hate to say that they're in addiction. So let's not say addiction. Let's use the words dependence and recognize that there's physiological dependence and psychological dependence. When we introduce a product, a chemical, a substance into a person's body, that body tries to create a balance or homeostasis and accepts that substance. And if we consistently introduce that substance, then the body does not have to make as much or starts craving it. This is physiological. Psychological dependence is when they are actually moving towards the chemical, or they have the craving even though they've had adverse events. So with our people, just showing drug addiction, where we got our big population there is 18 to 25 years old. So when we're looking at these, we're just taking an idea of, okay, if somebody comes in, they're in this age group, this is something that we might be concerned with. Go to those bubbles there, Troy. Thanks. This was shocking to me when I was looking at this. This is from JAMA Kaiser. Mental health and substance use disorders were the leading cause of disease burden in the US in 2015. So mental health and substance use disorders beat out cancer and tumors, cardiovascular disease, injuries, musculoskeletal disorders, diabetes, nervous system, all of these other diseases. So now we have mental health and substance use disorders, the leading cause of disease burden, and then we also have our overdoses beating out car crashes and gunshots. Let's go. Oh, that's me. Okay, so screening, brief intervention, and referral to treatment. So that's SBIRT. Screening and assessment tools are used to obtain an overview of the person's lifestyle through their self-reporting, substance use, and mental health needs. Screening and assessment help the physician quickly identify and provide early intervention and or referral for substance use disorders and the appropriate level of care. They save the patient and physician time, distress, and money through the patient's life. We create a synergy between primary and secondary healthcare services and specialty drug and alcohol treatment services. And screening and assessment tools may be used to help nurses identify quickly uncovered risks that problems with drugs and alcohol use. And paraprofessionals can administer and score screening tools. Who uses screening tools right now in your practice? Dr. Patterson, Dr. Lewandowski. Just a verbal is good. There we go. Okay, I got a wave. All right. Which screening tool do you use? Or tools?
Oops, sorry. I use the, depression screening tools, anxiety screening tools, and substance use for my buprenorphine. We have some screening tools that we use for that.
Okay. Are they helpful?
Very helpful.
Okay. Which ones do you use?
The depression screening, like the Beck kind of. There's also an anxiety one. I don't remember the name.
That's okay.
And one of the substance use disorders and opioid withdrawal rating, self-rating scales, cows and sows, those kinds of things.
Okay.
How easy are they to use?
Very.
Do you have them fill it out in the waiting room before their appointment?
Usually in the room, not in the waiting room, just because it gives them, I think, more sense of privacy in the room.
Okay.
It doesn't take long to fill out, just a few minutes. So I have them do that before I go in, but it's in the room, not the waiting room.
Do you look at the score, or do you have somebody else score it for you?
I look at it myself. Yeah.
There you go. Okay. Thank you. Also, it's not what the person has, but it's also ruling out comorbid acute and chronic pain disorders and opioid dependence. We want to make sure that there is not the polysubstance use is causing the actual disorder. So we want to rule out all of the other options that could be out there. Ruling out co-occurring psychiatric disorders, mental health screen form 3 is a good one to rule out mental health screening. Screen for infectious diseases, domestic violence, abuse, or trauma. This is where I run into a lot of the issues that I have with my people. This is a DSM-5 substance or medication-induced disorders. How many of your people present with anxiety or depression or major or mild neurocognitive disorders? Obsessive compulsive and related disorders, psychotic disorders, sexual dysfunction, sleep disorders, bipolar and related disorders. All of these disorders, I'm able to recognize. Now, I'm not able to treat them, and I don't want to. That's where I would refer to a specialist. But has anybody seen anybody on methamphetamines? Woohoo! Yeah, you're up for a ride. Yeah, and the idea there is, okay, this person is under yeah, they have anxiety. You can see that manic phase if you're looking bipolar. There's definitely some neurocognitive things going on with obsessive compulsive. There's a psychotic, it's a highly sexualized class of drugs, the stimulants, and they haven't slept for 3 days. So I can knock out all of this stuff with one simple drug. Has anybody worked with anybody on heroin? Hey, there we go again. It's completely a completely different animal. This person is leaking from every area of their body. It looks like they're crying. Everything that the opioid has constricted or constipated now is coming out. And with that comes some really uncomfortable withdrawal symptoms. And so when they're hurting in that way, this is the opportunity to get them to the care that they need. And you can do step-down therapy with that. Our MAT people talk about that with Suboxone. And so you can help them through that. But the idea is when they are on a substance or medication-induced disorder, is to get them to the appropriate level of care in a gentle way. And what I do is I let them know what they're going through and then what they can expect to feel as they're going through this in some sort of a timeline so that they can recognize, you know what, my body is getting better. And it took me time to get into this disease state. It's going to take me time to get out of this. And right now, I'm going through, I could be experiencing post-acute withdrawal symptoms in a couple of weeks. If you have somebody on benzos, that can take months to get out of that person's system. And if they've been taking benzos for 10 or 20 years, then we have even a longer period where their body has become physiologically dependent. So when we can noodle out any of the drugs that somebody is taking, then we can take care of a lot of these things right off the bat. Save the person a lot of time, effort, and energy. So we have the audit test, that's for alcohol use, DAST. These are all 10 questions. Mental health screening form, 3. Teen screening form. All of these are relatively short screening tools. And again, they're just screening tools. You're just trying to get a snapshot or insight as to where that person is. These are not thorough clinical psychologist testing. These are just a snapshot, again, of where the person is. So this is how easy questions can be. If you have time for one question, is alcohol that you're concerned about. For men, how many times in the past year have you had 5 or more drinks in a day? For women, same question except for 4 or more drinks in a day. For if you only have time for one question and we're looking at drugs, recreational drugs include methamphetamines, marijuana, inhalants, tranquilizers, barbiturates, hallucinogens, narcotics. So the question for one, if you only have time for one question, is how many times in the past year have you used a recreational drug or used prescription medications for non-medical reasons? Answer yes or no. For if you only have time for one question for an initial screening for mental health. During the past 2 weeks, have you been bothered by or had little interest or pleasure in doing things? And in the last 2 weeks, have you been bothered by feeling down, depressed, or hopeless? If you have a yes to either of these, that'll tell you to move forward to a more thorough assessment. Generally, you have a little bit more time. But if you recognize that there's a problem with the person in front of you, like you can smell alcohol or just something's not right in the exam room, you could ask them one of those questions. Or they're feeling really down or depressed, ask them these 2 questions, and that'll get you an idea of a deeper screen. These are the questions on the audit test. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have in a typical day when you're drinking? If you're familiar with the CAGE screens and different screens, you'll recognize a lot of these questions are consistent. They're just put in different orders. How often do you have 4 or more drinks on one occasion? How often in the last year have you found that you are not able to stop drinking once you started? How often during the last year have you failed to do what was normally expected of you because of your drinking? If you're familiar with DSM-5, this will also start with the diagnosing kind of questions. How often during the last year have you needed a drink first thing in the morning, like an eye opener? How often last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been unable to remember what happened the night before because of your drinking? Have you or someone else been injured because of your drinking? Has a relative or friend, doctor, or other healthcare provider been concerned about your drinking or suggested you cut down? So score 0 to 3. For a woman, low risk. 4 to 12, risky use. 13 to 19, that's harmful. For men, 0 to 4 indicates a low risk. 5 to 14, risky. 15 to 19, harmful. Low risk means basic education on alcohol would be appropriate. Risky, you might want to concentrate on some behavioral changes. Harmful and severe, you need to refer, get that person some help before it gets worse. DAST. This is, first you want to identify the drug being used. We have meth, marijuana, pain thinner, or inhalants, Valium, perks, cocaine, heroin, oxycodone, methadone, LSD, mushrooms. Even if they have a recommendation from someone, you want to know all of the substances in their system. You want to make sure that you're getting a blank slate or you know what's going on in their system. So any of the drugs that they're using, including vitamins, you want to know. Here are the questions for the DAST questionnaire. You can read through them. And 0 is healthy. 1 to 2, education and continue to monitor. If they score 3 to 5, it's harmful, brief intervention or referral to specialists, and 6+ is severe. So you definitely want to refer to a specialist. So when we're talking about tools, and we talked a little bit about some screening tools or assessment tools. So let me ask my experts here, my doctors, what tools do you use, Dr. Patterson, and how do you set that up with Dr. Lewandowski? And
yeah, so I'll go through kind of what we do in my office, and I've actually kind of got it written down here on my phone, so forgive me if I reference it. So basically what our office is interested in is opioid risk tools, right? Because we're obviously chronic pain management, where a lot of patients are being referred to us to take over their opioid management, and so we're trying to risk stratify from the get-go. So when patients come into our clinic at the initial consultation, we have them do Dr. Lewandowski's medical stability questionnaire, which I'll have him talk about in detail after I go over what we do. In part of his MSQS that he's got in this is he's also got the ORT. So the ORT is the opioid risk tool. It's a simple 4 questions, but it's mixed in with his questions, so the patients don't really know that we're going after opioid use. It just seems like they're just answering random questions.
Okay.
So they don't feel judged. And so every patient who comes to our clinic, whether they're on opiates or not, takes this medical stability questionnaire, because even patients who aren't on opiates, we're looking to see if they're high risk for treatment from a psychosocial standpoint, or see if there are some psychosocial risk factors that we need to look into in order to help them get better.
Right.
So every patient at the first appointment takes that test. We end up, after they leave, grading the test, and then if they're moderate to high risk, we end up going over the results with them the following visit. If they're low or low to moderate risk, where we don't think intervention is needed, we either consider retesting them in 3 to 6 months, or consider looking at more physician-driven assessments if we see behaviors that aren't consistent with how they scored on the test. So let me go over, if you're looking for different opioid risk tools at an initial appointment, I'll give you some recommendations here. And so there are 2 ways to look at this. One, are they patient-driven? Meaning, do you give an assessment to a patient and have them fill it out for you to review? Or there are physician-driven assessments based off of the referral and what you see on the PMP reports, or maybe their drug screen if you get it that day, what comes back. Those are more physician-driven for you to decide if they're low, moderate, or high risk. So the ones that patients can fill out, you've got basically 5 of them. You got the ORT, you got the SOAP, the SOAPP, or you have the SOAP-R, the SOAPP-R, or you got the SISAP, SISAP, or the last one, the 5th one, is the PMQ. I was over the weekend actually reading some articles that looking at drug screening and frequency and how often you should do it, and they talked about risk assessment. And I guess there was some paper, which I'm trying to track down now, that showed that the SOAP-R was probably the most sensitive and best screening tool out of all of them. And I think that's about a 20-question test, and it will risk stratify people to low, moderate, or high risk. And so I think if you're talking about getting low, moderate, or high risk, I think the ORT and the SOAP-R are the only ones that do that. I think all the other risk assessment tools will either put people at low or high risk. Now, if you're looking at the initial assessment, you're looking at physician-driven assessments. There are only 2. There's the DIRE, D-I-R-E, or the ALTURI, A-L-T-U-R-I. And so those are you filling out questions based on your initial assessment of the patient. Now, moving forward, as you see the patient over time, you want to continue having a risk assessment, right? So 6 months out, does this patient develop problems with their opiates? Well, so you got two different tools that you can do as you treat them. And so one is, once again, patient-driven, and that is the COMM, the C-O-M-M, so that's patient-reported. Or you have physician-driven ones, which are the ABC or the CHABAL, C-H-A-B-A-L. And so those are assessments that you would fill out on behalf of your review of the patient over a 3 to 6 month period of time. In our clinic right now, we're just doing the initial assessment. We're using the ORT. We're thinking about switching to the SILPAR. But moving forward, we don't have an ongoing assessment. Usually it's just more or less if we see abnormalities on their board of pharmacy or urine drug screenings that we're doing, then we'll put the patient in a higher risk category. So we do it more based off of what we see objectively. But we are thinking about now, moving forward, probably trying to use the COMM. And if we just think that the patient isn't giving us honest answers, then doing probably the CHABAL for us to grade the patient on what we're seeing over time. Anybody have questions on any of these or want me to expand upon any of them? Yeah, absolutely. Go ahead.
So when you've done this risk stratification, then how does your treatment change based on those scores? Does it change your treatment?
Well, so yeah, it absolutely does. So we have a marriage family therapist in our practice who has a drug and alcohol addiction background. She did 2 years of working at Step 2, doing daily education with patients addicted. And so anybody who tests to the moderate to high risk with the opioid screening who are on opiates, we make an automatic referral to her at the second appointment. And we try to get her involved to make sure that there isn't an underlying substance abuse issue that we're not aware of. Patients who decline to see that individual, then we decline to continue opiates moving forward. So basically, it's a way for us to reassure ourselves that we're not, putting a patient on the railroad tracks and going to send the train down the tracks. Do we get a lot of resistance at times? Absolutely. There are patients that will absolutely refuse to make that appointment, or they will make that appointment to appease us and then cancel. And so that's good for us to see. We try to be more polite, I think, about it at the beginning. Like, hey, I'd like you to see this individual. We don't really tell them why. But when it comes down to it, several months, if they keep canceling an appointment or not making that, then we'll be more firm and say, hey, I can't continue to prescribe you medications until this assessment's done. These individuals also, if they're refusing to see it, we may go to seeing them more often, maybe giving them a week's worth of medications. While we're waiting for them to get into this individual, or we'll try to make it even more convenient. Hey, why don't I see you? I give you a week's worth of medications. I'll see you in a week, and next week when you come to see me, you already have an appointment set up with this individual. So I'll see you after you see them, and then I can get a quick verbal, like, hey, there's nothing going on here, or oh yeah, you better be careful. I'd recommend. She gives us recommendations on how often she thinks we should drug screen.
Do you know what screening tools she uses?
Yeah, more.
Yeah,
I'm not sure what screening tools she is using currently. But that's an excellent question. I should look into that.
The reason for that is if you don't have the luxury of somebody right there in your practice, maybe you could do one of those screening resets.
Well, the hardest thing I've found in the past, without having a person in our practice, it's hard to, patients will come back and say, well, I already saw that person.
Yep.
And I'm like, well, I haven't seen anything. And then it makes it a burden on myself and my staff to try to track down that assessment. Or, a lot of times, well, I never got a phone call. They never called me to set an appointment. And I don't know if it's just they don't take their insurance, or did they not reach out to the patient? Did our fax not go through? That also leads to a lot of work on myself and my staff. So bringing it in-house has been a luxury for us, because now we can really keep track of what has happened. But if you don't have that luxury, then I make sure that you have a go-to person that your office has a good relationship with, so you can call and ask these questions. Did you guys reach out to this patient? Did this patient come and see you? So you can actually keep track of what's happening. And there's another question.
That was actually my question. Hi there, I'm Dominic Nardini, MFT. Is there a system in place that you can track whether or not they've made that appointment? What's the communication like after you've referred them to mental health?
Usually what we end up doing is we make the referral to mental health, and then we'll actually even give them the appointment to that person's office and say, hey, look, we're going to fax this referral over, and if you haven't heard from them within 3 to 5 days, here's the number. Please give them a call to see where your referral is at, or call us and ask us if the referral went through. And so we try to keep it, and we assume that if we haven't heard from the patient in 5 days or from the referring office, that it's taken care of. A month later, when I see the patient, it'll be part of my plan of care. Hey, I referred you over to see Dr. such and such last month. Has that appointment taken place yet? And then usually I'll document in my note, if it's pending this date. Oh, it took place on this date. And then usually I'll document like, hey, I'll have my office call to verify the appointment's going to take place in 2 weeks, or I'll call to verify the appointment took place 2 weeks ago, and I'll see if they've got their office note to fax over, which I'll review before next visit.
Okay, thank you.
Take place where they say they haven't heard from them, I'll have somebody in my office call their office to find out if they make sure they got the referral, and ask them if they've reached out to the patient. A lot of times then, they'll come back in before, after I leave the room. This will all take place before the patient is checked out. And a lot of times, I may find out, well, they called you, they called 3 times and the patient never called back. At that point, I will walk in the room, give the name and the number of the individual, and say, hey, they called you 3 times. You did not return their phone calls. I expect this to take place before I see you in 4 weeks.
Nicely done. Yes.
All right, any other questions on that? Opioid risk tools?
Let's talk about designing them. Dr. Lewandowski, how would you design, or how did you design this screening, assessment, testing kind of a program with Dr. Patterson? What did you look at? How did you do it?
I think that for people with persistent pain, one of the big things is that they want to feel like they've been heard, that they want to have a voice. And so as a psychologist, who loves to do assessment, I figured out, is there a way that we can give them a voice in a very short, quick kind of fashion, so that you, the physician who has limited time, could kind of read that story very quickly. So, having seen a lot of folks with chronic pain over the years, there were some areas that I knew I felt that were important for doctors to understand, which is, what is their perception of their medical treatment? Do they have an understanding of what their pain generator is? What are their actual pain ratings? Are they in the upper, middle, or lower third of a pain scale? And then, of course, the psychosocial, the depression, the anxiety, and the anger that you typically see with people with chronic pain. I wanted to be able to measure that. So, you try to do that in a very quick, short fashion. So one of the values of screening tools is that you give the person a voice. They can feel heard, ideally, through the data that the doctor gets from that screening tool. So it doesn't have to be punitive, it can be very informative. And so that was, my attempt, is to try to give them a voice, be efficient with time, and get accurate data to the physicians quickly.
And Mike makes a good point here. When we started using these assessment tools, we as providers made a mistake. And what mistake I'd say is we made them more punitive. And so the next visit when we'd see patients, we'd be like, oh my God, you're high risk, I need to refer you out, and kind of like startle a patient and make them feel like I judge them. And then when we'd send them over to see our internal behavioral health person, they would show up with a chip on their shoulder and not very open to the idea. And I think we made it very difficult on ourselves. We made it very difficult on our provider, and it kind of created this hostility. So I think we've taken more of a softer approach at it now, where I will go in with the results and I'll see what things that are highlighted that are risk areas. And so I'll say, hey, I had a chance to review that online thing last month you filled out. I really appreciate you taking the time to do that. I just want to share with you a few things that it caught my eye. One, how you filled up, your chronic pain. It seems it's from the way you fill this out, it says you've got high levels of depression due to your pain. I see that it's also causing you to have anxiety. And then I try to explain to them how it's normal for up to 70% of patients to have some type of depression or anxiety. And then I'll talk to them about how, hey, it seems like you seem to be, the way you answer these questions, it also states that you're angry and frustrated. That's normal. Yeah, I think I'd be angry and frustrated too if I've had pain for this long and hadn't gotten it taken care of. And so I'll kind of highlight those things and I'll say, well, hey, I think I got a person who can really help us work from a pacing or from a psychological standpoint on how to navigate these landmines. Let me put a referral into them and let's see what they can do to help you out. Maybe we can improve upon these with ideas they got. And I try never to use the word mental health. I try never to use the words behavioral health. I try to make it more like I've got somebody who's just, can, kind of help navigate these things. And what I've seen is that, I think, initially this person working for us, felt like, patients show up angry and like, well, why are you here? Well, I'm here because the doctor says I got to be here. Yeah. And now they show up and they're like, oh, he says you're going to help me. What can we do? And I think it's a little bit more. So if you're going to use these assessments, Dr. Lewandowski's right. Do not make them a punitive.
In a way, you turned it into a way to reduce the resistance.
Correct.
And to believe like you're actually listening to them.
Correct.
Yeah. And so.
Do we eventually become punitive? Yeah. If after 3 or 4 months they're being non-compliant, as we discussed earlier, then I'll tell them, then I may have that point where I'm saying, hey, look, I can no longer continue to prescribe to you unless you have this assessment.
Yeah.
Then at that point, it may be a punitive thing, but those are few and far between with the way that we've been able to handle this better yet. As primary care providers, if you refer over to me, you got to be aware that sometimes when we try to get these assessments done, I think the patients will take the path of least resistance, and they may come back to you and tell you that that they are not happy, and it's probably because we're trying to get them in with some type of an assessment like this, and they may return to you to get their opiates and look for you to refer them else to somebody else because they don't want to go through these assessments. So just be aware of that.
It sounds like an art form and a progress.
Yes.
And a process.
Yes, big time.
And it's narrowing it down to the exact scope that you need for your individual practice. All right, do we have anything else that we'd like to add? Any questions, concerns?
I do have a question. This is Dr. Marie McCormick at Renown. So we have a policy for primary care that they do not prescribe past 50 milligram equivalents of morphine, and that if they have patients who are requiring more than that, that they have to go to pain management. I'm hearing from the providers that they can get a pain management consult, but then they're being sent back to them for the provider to prescribe, which the provider by our policy is not allowed to do. I just wanted to know Dr. Patterson's thoughts on all that.
Yeah, so I mean, our clinic, if you send them over to us, we'll take over. We don't send the patients back to you. I think you may find instances where patients are upset that they got to come to see us because their copay to see a specialist costs more than to see you guys. I've seen situations where some of the primary care providers were given 90-day prescriptions, where somebody's on a Schedule 2 or Schedule 3 substance. We do every 30-day visits, so the patients are upset about that as well. So I don't know, from my clinic, we would never see them once or twice or give guidance and send them back to you to prescribe. We would assume all care. I know your guys' pain management specialist, I don't know, is that who you're referring to? Is he the one seeing them send them back?
Dr. Salas has pretty much gone out of the pain management business. They're all going to go over to physiatry because we've hired 4 spinal guys now. So it's all going to be community based, and you're absolutely correct. Patients are coming back saying, well, that's a higher copay, or they want to see me every month, to which my answer is, that's your choice if you want to be on this drug.
Yeah, I kind of agree.
It's not something that we play with.
Correct. And I have patients tell me all the time too, like, doc, I can't afford a drug screen, or I can't afford this. And I just straight out tell them, well, I can't afford to lose my license over prescribing you these medications. Your call.
I absolutely Agreed. I just wanted to be sure we were all on the same page. Thank you so much.
Yeah, and actually, Marie, you raised some good points, because there's other primary care doctors out there that probably don't agree with me saying that. And to them, they just want me to deal with it. And when I kind of hardline the patient, it's disappointing to me when I call the provider and say, hey, here's what's going on. I'm looking for them to back me up. And if they back me up and the patient comes back, then I think we have no resistance. But when they go back to their primary care and their primary care is like, okay, well, I'll just send you to someone else, they're kind of shooting me in the foot and not giving me that control to get that patient under control. Does that make sense?
It absolutely does, and I guarantee you that's not happening from the renowned providers, because I'm the one that wrote the policy, and I'm the one that's policing it. And we've actually put somebody on an performance improvement project over prescribing, and that's well known now across the group. So they are very careful about the rules, and they are following them perfectly.
What's interesting now is that, doing what I do, I kind of have an idea who is more loose prescribing in the community. And what I've seen now with your guys' referrals, especially in the last 2 weeks, I've seen patients go into your providers and specifically ask to see certain pain management doctors in the community that I would say are a lot looser in prescribing than we are. And I find that fascinating. So
I think
it's word of mouth.
That might happen now, Dennis, because of the only way that would happen would not be on patient request, but because of the ACO, if they are patients that are under the ACO, they are only allowing us to send those to pain management specialists that are also in the ACO. That'd be the only way that would happen. And we pretty much are like you. If they're asking for somebody, we're like, oh, really? I didn't just fall off the turnip truck. There's a reason you're asking for this person. So the word on the street, we kind of have the same. And then the other thing, one other thing I wanted to bring up is the fact that I've had times where we've had patients who were, when you go into the PMP, you figure out that they're seeing pain management and DAST. And when we have that happen, I've always encouraged the providers to call the other doctors to let them know what you found, so that we're all on the same page, exactly like you're saying. And what we tell the patient, I mean, they get all angry and everything, and I just tell them, look, this is playing with your life, and we're not willing to do that. That's not what we went to school for.
Correct. And I told them I took an oath to do no harm, and unfortunately, prescribing certain meds and certain levels, I'm probably going to do you harm. And then the other thing I talked to them about is that, I've never seen anybody die, or I've never seen pain as a cause of death on a death certificate, but opioid overdose we see all the time. And so I told them I'd rather them be, have some pain than to be dead, i.e. no pain at all with overdosing from their medications.
I absolutely agree. Thank you.
You're very welcome. Anybody else got questions?
I just want to bring up the importance of the interdepartment communication. In working with a psychiatrist right now as an MFT, we're working on tapering off of opiates, and what I'm being sent is that angry, chip on the shoulder client that we need to prepare for. We've involved security, we've involved screening the client before they're met in our office. That's been a big issue, is dealing with that client that is coming in for a fight.
Correct. I couldn't agree with you more. Like, I'd say, 10 years ago when I started this, there wasn't so much anger, and it seemed like it was more acceptable to prescribe opiates. And I remember if people's PDMPs were all right, their drug screens were consistent, and they complained of more pain, then I think, oh, okay, well, maybe I'm inadequately treating their pain, I'll increase their pain medications. Nowadays, my goal is to maintain or decrease, not to increase anybody. Because I realize that opiates probably aren't the answer, and they're not, doing the patients any good. And I think there's actually going to be a study that comes out that I just, I was reading about the other day that just finished, that showed that use of Tylenol and anti-inflammatories for 12 months for chronic pain showed increased function and less pain scores in patients who are on opiates for the last 12 months. So that's going to be published coming up. And so, that's our goal, is to do that. And you're right. What's happened now is there's pressure on doctors to stop prescribing or decrease their prescribing, which is leading to angry patients. And unfortunately, we're the ones taking the brunt of it. to me, there needs to be some skin in the game for the patients, right? And right now, there's no skin in the game for patients, and so therefore, they're going to be angry because they think, you can do this, I know you can do this, and you're just not going to do this, and so therefore, they're angry at us. And you're right, you know, people passing the laws telling us how we should prescribe is faceless, so they can't, there's no way for them to take their anger out on them, correct? Wouldn't it be great if the state of Nevada linked their PDMP with their DMV, with the DMV, and when the state sees that somebody gets a certain morphine milligram equivalent a day of pain medications, they also get a notice from the DMV that they got to turn in their driver's license? I think that would really change people's perspective. Guess what? They'd get that letter from the DMV and they'd probably be in the doctor's office asking them to wean them off their pain medications so they can keep their license. So that's the problem right now, is we have no skin in the game for patients. And I think that's what the powers that be need to look at, is they need to get some patient involvement in these decision-making process so the patients aren't as angry and frustrated with us.
But you know, this is an incredible point. With the 142 deaths a day from overdoses, it's not always somebody who's looking to overdose or to avoid withdrawal or to feel euphoria. It could be the person who's taking their medication incorrectly or making a mistake, or I'll just take another one and I'm going to have a glass of wine with it.
Well, when I explain that to patients, patients all the time say, well, this opioid epidemic is for patients who are abusing their meds. And I say, no, that you're incorrect. These are patients who are taking their medications as prescribed. Well, you know, doc, I've been on these pills for 10 years. How does this happen? And I tell them examples of patients in my clinic where I've gotten phone calls from the hospital. Hey, your patients here, they are basically on life support, or, you know, because they've overdosed on their meds. And I look at the records and I'm like, I haven't changed their medications in 3 years. What do you mean? Like, this isn't, you know. So what ends up happening is there is a change in the patient's health status. And when there's a change in the patient's health status, how the medications bind in their system changes. So what can happen is that normally these medications probably bind to proteins in their blood and go throughout their system. And if all of a sudden how their affinity for binding these proteins changes, it'll make them more readily available, which then can lead to an accidental overdose.
Yes.
So the classic patient would be a 65-year-old woman who develops a urinary tract infection. It's been on pain meds for 2 years. That urinary tract infection, if it gets in her bloodstream, now her pain medications, you know, act differently. They lead to her having a respiratory arrest, even though I haven't changed her meds in like 2 to 3 years. And so I explain that to patients. Hey, as you get older, your health status is going to change, and as it changes, you may have one of these issues. Or say you go to your primary care, you develop a new disease process. You're started on a new medication. That new medication may change how the enzymes in your bodies metabolize that drug and may make it higher in your blood, and you may have an overdose. So it's not necessarily misusing or not taking them as prescribed. You can take your medications as prescribed and be just as vulnerable as a patient who's misusing their meds.
Absolutely, and it's not that the person doesn't want to breathe, it's that the brainstem forgets to breathe.
Correct.
So when these systems shut down, it doesn't matter what the chemical is, if it's illegal or legal, it's a chemical, it's in the body. Like the trifecta, oxy, soma, benzos, yeah. Put those together, add a glass of wine, or you don't even have to add that wine.
No.
And you're on the, yeah. All right, well, we're getting the wrap it up sign. All right, thank you very much for being here. If you need it or you have any questions about screening tools, assessments, I can get in touch with the physicians real quickly. I just have my contact information here. Please contact me and we'll get you whatever you need within reason. All right, have a good day, everybody. Thank you very much.
Oh, that's it, right? Yeah, okay. Okay.